Welcome, everyone. I am going to start on time today. I am really excited to have you all join our webinar today. I am Rachel Stein. I'm an SVP at Health and Commerce. I'm going to be moderating the session. We have a very exciting agenda ahead of us today, so I would love to just jump in. First, we're going to introduce our distinguished speakers, Drs. Eagle, Estrera, and then also Meredith O'Neal from the John Ritter Foundation. And then I'm going to have Meredith jump in and talk through a little bit about her story, her patient perspective, and provide a little bit of an overview of the John Ritter Foundation. From there, Dr. Eagle and Dr. Estrera will guide us through the new Ritter rules and their expert perspectives on the state of aortic health. Finally, we're going to close with your questions in the Q&A. To keep the conversation moving, though, we kindly request that you hold your questions until the end of the webinar. We will take them via the direct message, and I will read out the questions and direct them to the appropriate panelist. If you're having any technical issues during the session, please ping. You should see webinar support / Carrie Kong on here, and she will be able to assist you. And with that, I will formally introduce you to our esteemed speakers. Dr. Kim Eagle is the director of the Frankel Cardiovascular Center at the University of Michigan Health. He serves on JRF's advisory board and is a leading expert in aortic dissection. Dr. Anthony Estrera is the chair of the Department of Cardiothoracic and Vascular Surgery at UT Health Houston. He's also a member of the advisory board at the John Ritter Foundation, and he specializes in aortic diseases, including aortic aneurysms and aortic dissection. And last but not least, I have Meredith O'Neal, who is the CEO of the John Ritter Foundation. She's also a survivor of thoracic aortic dissection herself, and she comes from a family with an extensive history of aortic dissections as well. With that, I would love to turn it over to Meredith to introduce herself and tell us a little bit about her story as well.
Good afternoon. Thank you, Rachel. And I would like to personally thank Dr. Estrera and Dr. Eagle for being with us here today and giving us their time. You can see the pictures attached. This is myself and my family with my surgeon and the OBGYN who did my C-section. When I was 37 and a half weeks pregnant, when I was 33 years old, I had a type A dissection, which required emergency surgery. Not only did I have a C-section, but I also had open chest surgery and an aortic replacement on the same table. What is not unique about my situation, but I was the fifth dissection in 4 generations in my family, and it took me by surprise at 33 years old. And so I became extremely passionate about this, as it is a very fatal disease. And I was lucky. I was one of the lucky ones who survived. And my son and I just had we call it the 7th aortiversary in the community, but my son also turned 7 years old. His name is Jeffrey. So I'm passionate about education, and my symptoms was a tearing pain in my chest, and my back really started hurting. And I really was just hoping that I was having weird labor pains. And unfortunately, or fortunately, they figured it out very, very quickly. And unfortunately, I was having an aortic dissection. And, they told me to say goodbye to my husband and to make some really hard decisions. So I'm extremely passionate that everyone in my story, everything went right. And so I want to make sure that everything goes right for others. But I'm not the only person who's had an aortic dissection. It spans every age, every race, every geographic, every socioeconomic area. So Rachel, if you can go to the next slide, these are some other people who you may know that have had aortic dissections that I just wanted to highlight. Obviously, we lost John in 2003 to an aortic dissection. Then you'll see Flo Hyman, who was a volleyball player, and she died from an aortic dissection at the age of 31. Grant Wall, who you'll see in the middle picture, he died when he was covering the World Cup. It became national and world news. Now we help support his brother and his family. Lucille Ball died of an aortic dissection later in life. James Donaldson, a former NBA player, survived his aortic dissection. And then Richie Faulkner, the Judas Priest guitarist, survived an onstage aortic dissection because of the quick actions of EMS. So most of these people did not know that they were at risk. Some have family history, some have syndromatic things that are within what they could have. They are symptomatic in that terms, but really they were asymptomatic. Some of these people had aneurysms that they didn't know about. So it can happen to beloved figures within our community, but it also happens to everyday people every single day. So I was 33 when I had my dissection. My mother was 38 when she had her dissection. My grandfather was 59 when he had his dissection. And these are some of the other people. Caitlin, the sweet girl in the top left, she died at age of 15 from an aortic dissection. Carmen in the top right, she survived an aortic dissection at 33 postpartum, and she was the first survivor I spoke to outside of my family. And then you have Hetty, who survived from an aortic dissection, and then Desiree lost her husband, and Michael survived a dissection. So, like I said, it really happens to anybody within our community. There's no age, no race, no socioeconomic background. It can happen to people who appear healthy, and then they have a catastrophic event that can sometimes turn tragic. And so patient education, family history screening, and regular imaging are incredibly critical. So the John Ritter Foundation was formed by Amy Yazbek, John Ritter's widow, back in 2003 after John passed away suddenly. And it has grown into this huge resource and authority for aortic dissection education and research. And I wanted to let you know that the johnritterfoundation.org is a great organization with lots of educational tools. We also provide funding for aortic disease and aortic dissection research. And we have so many patients that are ready and willing to share their story if that interests anybody who's on this call, not only myself, but there are plenty of stories just like mine. So I wanted to thank you again so much for having us here today. And we really hope to shine the light on this often under-recognized disease.
Thank you, Meredith. And now I'm going to turn it over to Kim to talk to and explain a little about the new Ritter rules.
Great. Yeah, thank you. The Ritter rules, to honor John, are really all about trying to figure out how do we empower and families to have a higher suspicion for this really dangerous but rare disease. It's aortic dissection is probably 200 times less common than heart attacks. And so, unfortunately, many people out there have never heard of it or haven't seen it if you were a provider. And the John Ritter rules are designed to raise awareness of both providers and patients and families, and indeed the community and people like you, reporters, to this condition and how we can recognize it and hopefully both prevent it and treat it better. The first Ritter rules were published in 2011 after the national guidelines on aortic care were provided in 2010. The guidelines were updated, the guidelines for providers caring for patients with aortic problems in 2022. And the latest Ritter rules are in parallel with that document. But I would say they're shifting the audience not just from doctors to also patients and families. We need to empower individuals in the community with both the knowledge and the courage to seek the best possible solutions for their healthcare. There's also a new emphasis in the Ritter rules about survivorship. It's one thing to go through an ordeal like Meredith did and survive. It's quite another to thrive. How do we help patients and families who've had an aortic dissection thrive during a life instead of simply getting by? That's an important part of what we're doing with the Ritter rules. And the next slide. So rule one is to be your own advocate. And we need to teach our patients and families who have aortic disease or may be at risk to be informed about thoracic aortic disease and to actively participate in their journey. They can't be innocent bystanders. They need to be active members of their care. We need to embolden them to seek second opinions if they're dissatisfied with the first opinion or they feel like they're being essentially dismissed. We have to encourage their attendance at regular appointments. If they don't see physicians and the practice of medicine on a regular basis, if they don't receive their medications to control blood pressure, if they're not getting regular imaging, which is required for effective care, then the likely outcome may not be optimal. And lastly, we want to get them to be knowledgeable and actively contribute to their own care in order to make proper decisions that are based on their wishes. The next slide. So another part of this is access. It's very important, especially in a society where access to healthcare can be challenging, for patients at risk for or with aortic disease to feel emboldened to build a care team. And one of those things that they need to do is to try to find a care team that has expertise. Not every provider out there is an expert in aortic disease, and not every provider is prepared to deal with emergencies that may come up in a patient or family with a history of aortic disease. So the Ritter rules really consider trying to encourage patients and families to connect with an aortic provider, typically a cardiologist, as well as a primary care provider who's aware of their situation, and it uses specialists as needed. In general, if a person lives in a population where a multidisciplinary aortic center is available, we think the care is better by integrating imaging, cardiology, cardiac surgery, et cetera. In general, we think patients get better care. They get more immediate access if they need a life-threatening procedure. And ironically, with telehealth, which largely burgeoned during the period of COVID, we can often take care of patients in faraway places from an aortic center like where I work. So we may have patients in outlying states who are seeing a primary care doctor, but they're getting their subspecialty care at an aortic center using a telehealth mechanism, which is a wonderful advance in healthcare. The next slide. It's really important for patients and families who have a tendency to genetic or to aortic disease to consider the possibility of a genetic cause. Up to 20% or more of patients who have an aortic dissection, which is this tear in the aorta, probably have a genetic cause. We know this because of genetic testing as well as family history. And now we have a very effective way of screening for the group of genes that can cause aortic dissection in families. And obviously, these are various types of genetic alterations. Each of them can have a different effect on the aorta. Some will cause the aorta to become enlarged. We call that an aneurysm. Others may primarily cause the aortic wall to weaken, and that can cause an aortic dissection. Knowing the gene in familial aortic disease allows us to be more precise in managing that patient and making decisions about the imaging protocols they need and when they might need preventive surgery, perhaps. Families need to know that if they have an aortic problem, we need to understand if family members have had an aortic problem. That would then lead to potentially to genetic testing. Also, it's important to recognize that sometimes a patient may have a family history of sudden death. There was no autopsy performed. And the assumption in our healthcare system is, well, that was probably from a heart attack. But we don't know that if there hasn't been an autopsy. So when Dr. Estrera and I are taking a history, when there's a family history of sudden death, we don't assume it's heart attack. We're thinking it could be aortic disease, and we need to keep that in mind as we evaluate that patient. Clearly, screening patients who have appropriate symptoms or a family history with echocardiography or a CAT scan or an MRA is really important in potentially identifying family members who had unsuspected aortic disease until the first patient got access to care. Next slide. I think this slide really talks about support. The survivorship after the knowledge of an aortic aneurysm or aortic dissection is something that we really are focusing on. And we did a study here where I work at the University of Michigan that showed that a third of aortic dissection survivors had depression. A third of them never entered sexual activity again. Many of them felt they were too disabled to work. Many of them had suffered from anxiety. We need to do a much better job at helping support both the mental and physical health of survivors. And the Ritter Foundation, the Ritter rules are focused on that. And that's a very important part of what we can do. And we want to involve mental health specialists whenever that is required. And the next slide. Clearly, one of the things that we've come to know is that when you've had an aortic problem, it's a lifelong problem. Even if Dr. Estrera replaces your ascending aorta, if it tears like Meredith's did, the aorta beyond that is potentially diseased, and it may be a problem over time. So that patient needs follow-up imaging at a regular protocol, depending on the type of problem. We want to manage the blood pressure and heart rate very effectively. We want to prepare for transitions across different life stages, pregnancy, getting older, etc. We have to think about work and what that means to a patient's aortic health. And we definitely want exercise and physical activity to be a part of what our patients and families do. But there may be some guidelines that we want them to follow in a certain circumstance to reduce the risk of certain types of activity. Next slide.
Thank you,
Tony?
Dr. All right, now we're going to turn it over to Tony to talk a little bit more about aortic dissection.
Thank you, Kim. Great job. And I also want to thank the John Ritter Foundation and Meredith and Rachel, for organizing this session. So Dr. Eagle has given you sort of the playbook of how we address aortic dissection through the Ritter's rules. I want to give you a little background of what this all means. So aortic dissection, remember, and this is what I describe to our patients. When we have a patient who has either a dissection or an aneurysm, and I'll describe what both means. It involves the aorta, which is what I call the main pipe of the body. You see there on the right, you have the heart, which is a pump. It pumps blood to all the vital organs of our body via this main pipe. And so when dissection occurs, we'll run the little video here, a tear occurs within that wall of the aorta that then splits the aortic wall, and blood can flow into both the true and now the newly created false lumen. The problem with that is that that weakens the wall, which can then tear or rupture, or that flap, as you saw earlier, can now block off critical structures throughout the course of the entire aorta. So every organ in the body can be affected by aortic dissection. Now, remember that an aneurysm is when that wall weakens and enlarges without a dissection, and you can have aneurysms without dissection and dissection without aneurysms. But I'll say that the most common aortic catastrophe is really aortic dissection, and that's what we're focusing on here. But I want you to keep in mind that both are somewhat related, and you have to really take care and watch both here. So, as Dr. Eagle mentioned earlier, unfortunately, the first time this may present in patients is with sudden severe tearing chest pain, back pain. That's what Meredith described in her case. And this happens about 80 to 90% of the time. There are situations in which they present with abdominal pain or eventual stroke, or sometimes these patients even rupture that leads to what you see there, shock. But it is a catastrophe when this happens. And our whole goal here is to try to prevent this from happening. In general, more of these cases will occur as we get older because the makeup, the biomaterial properties of the aortic wall, collagen, elastin, the half-life's very long. So what we're born with is what we have, and we never really regenerate. That's why these aortas, when you have an aneurysm or a small aneurysm, it'll never shrink. It can. Our main hope is to make sure it doesn't enlarge or doesn't dissect. Next slide. And so, what are some of the risk factors? As Dr. Eagle mentioned earlier, we have to keep in mind that this family history is maybe our only indicator to really keep track of someone who may have be at risk for dissection. On the right, up to 50% of the people with dissection will lose their lives without treatment. And that's why it's important to try to identify it, treat the patients, and then, if all possible, prevent it from happening if we know someone's at risk. And again, as Dr. Eagle said, 20% of the population with these aortic diseases can have a family history. So we can't ignore that. So we also have to keep in mind that the family history of even sudden death, Dr. Eagle mentioned that earlier, we think of that could have been a heart attack, but you can't ignore the fact that it also could be related to the aorta. And these patients, unless they get an autopsy, you'll never really know. Some of the other things I think about is really uncontrolled hypertension. That's a physiological problem that causes damage to the aorta that might be at risk. Bicuspid aortic valve is a condition that affects 1% of the population. So it's really common if you think about it. 1 out of 100 people have a bicuspid valve, and instead of having 3 leaflets, you'll have 2 leaflets. That's not as important, but it's just important to know that these can be associated with aneurysms in 30 to 40% of the cases, which then can be at risk for dissection. High intensity workouts like heavy weightlifting might put you at risk if you have an abnormal aorta. And these are the discussions that the multidisciplinary team has to have with these patients who are now being followed with aortic disease. And trauma to the aorta is listed last. It's not that common, but we have to keep in mind that motor vehicle accidents and things like that can cause dissection, but oftentimes those will be identified by the emergency centers. Next slide. What's the treatment and prevention? Unfortunately, there's no medicine that's going to necessarily cause a aortic dissection to go away, or an aneurysm to go away. Once you have a known aneurysm or dissection, you'll always have that. Really, the goal is to prevent it from growing or having new complications of new aortic dissection in someone who has had a dissection, or in someone who has an aneurysm, preventing that dissection from happening. So this is where prophylactic surgical repair. Dr. Eagle is a cardiologist, really an authority in aortic disease management, and I do a lot of surgery. So my objective is, once these patients come to my attention, they're usually being referred for a prophylactic surgical repair. Now, there are situations where we unfortunately take care of these patients in the emergency setting. You heard Meredith's situation where her doctor saved her life, and it happens too often in my mind. I was telling the group earlier that this past weekend when I was on call, there were 2 patients that presented with aortic dissection, and they unfortunately were delayed in their diagnosis. And they came, we had accepted them, and they never were able to make it to us because they died at the other facility before they could get surgical correction. That was sort of the situation with the reporter Grant Wall in when he was covering the World Cup. It's just unfortunate it gets to that, but that's why it's so important to try to identify those who are at risk, and it can be a simple CT scan or echocardiogram. The medications are really the expertise of Dr. Eagle, but the goal is to really control the blood pressure and to slow the growth. And ultimately, proactive management and even prophylactic surgery is so important, because once we can prevent that dissection from happening, it affects and improves the quality of life as well as the longevity and long-term outcomes. Because once you have a dissection in your aortic wall and the remainder of the aorta, then that becomes a real problem. I'll say that surgical repair, remember, as a surgeon, you have really 2 locations of these dissections, one in the front by the heart and one in the back that goes down the middle of your back. And if it involves the front by the heart, we will do a repair of that segment, but the rest of the aorta may still be affected, and that's why lifelong surveillance is required. Next slide. And this is just a sobering slide in that 80% of the patients who develop dissection and or death um, could survive with prompt diagnosis and treatment. That's why it's so important to not ignore this, and as a patient, your be your own best advocate. And as was mentioned earlier, Dr. Eagle and Meredith have been trying to really educate through the John Ritter Foundation the primary sort of first line caretakers who see patients up front, both in the emergency rooms, primary care, internal medicine, family practice, to not ignore these kind of symptoms that might make you at risk for aortic dissection, and see the number. It's not as much as heart attack, but it's not insignificant when you're talking about 20,000 people each year in the US could be affected by aortic dissection. Next slide. I'll turn it over to Dr. Eagle on this slide as we go through what should we look out for. Kim?
Tony, great presentation. We were thinking about, what are the messages that we want to try to get out? And if we think about the providers, how would you think about them? And for cardiologists, we want them to be thinking of aortic dissection with patients who have any unexplained chest discomfort, or who have known aortic valve disease or have long-standing hypertension. And certainly if there's a known genetic family history, then they need to be all over that possibility for the patient they're looking at. And we need to remember that sudden unexpected death might have been due to an aortic dissection, not a heart attack. And if you asked me, a cardiologist, how are we going to screen the population for this risk? Actually, we potentially have the ability to do that much better than we have, because we're currently screening our middle-aged patients with something called a coronary calcium score, which is a 5-minute CAT scan, primarily looking for evidence of calcified plaque in the coronary. But that test gives us a picture of the aorta in the thorax and can actually identify patients who have an enlarged aorta. So one of the things we want our cardiology colleagues to be thinking about when you get a calcium score, make sure you take a look at the footnote. What did the radiologist say about the aorta? And for the radiologists, they need to put that in bold. If they find a patient in a calcium score study that has a big aorta, we need that to be in bold, because otherwise the cardiologist might just be looking at the calcium score and not see the footnote about aortic size enlargement. For people involved in OBGYN, they need to hear Meredith's story. They need to know that a woman having chest pain in peripartum moment or late in pregnancy, we can't just dismiss it as some discomfort related to the child pushing up on the diaphragms or shortness of breath. Think aorta, especially if there's this family history that she had. Must not dismiss it and look for, the rare disease, but potentially very dangerous disease. For emergency medicine, they really need a checklist. What are the 6 things you got to remember when you evaluate patients who have abdominal or thoracic pain to not miss dissection? And it's pretty simple, right? It's a known aortic valve problem. It's a known aneurysm. It's a family history of aortic disease. It's a known genetic aortopathy. It may be chest pain and another symptom like fainting or a stroke. And the fact that the EKG, which is routinely done, doesn't show a heart attack. So if there's no heart attack and the patient is still having pain, oh, okay, that might be something different. That could be something dangerous. And I need to look for an aortic dissection. For primary care doctors and providers, this is a huge challenge, isn't it? It's a rare disease. They may have never seen one. And so we're trying to, again, try to get them reflexive in how they think about screening for aortic disease. And the family history comes immediately to the fore, recognizing how important poorly controlled hypertension is to risk. recognizing that certain patients with genetic defects have a look to them. Their eyes may be widespread. They may have sort of translucent skin. They may have skeletal changes that suggest something like Marfan syndrome or Loeys-Dietz syndrome. They may have had abdominal or pain or chest pain that was unexplained and nobody ever figured it out, and they saw a slightly enlarged aorta on a chest X-ray. So just creating a simple checklist for frontline providers that has them tick these things off, we think has a good chance to allow us to identify patients that otherwise currently go without a diagnosis and unfortunately often have sudden death in the days following an initial checkup.
Dr. Eagle.
Tony, anything to add to that, or Meredith?
Yeah, thank you, Kim. Great overview. The way I think about this also is that there's two sets of patients. Those patients who have now suffered aortic dissection and will need immediate treatment so that they can survive. And that's where the emergency medicine, Dr. Eagle talked about this previously, OBGYN, these situations in which the aortic dissection has occurred. I'll say that 30 years ago, Dr. Eagle was instrumental in developing the International Registry of Acute Dissection. And in 1996, when they wrote their first paper on this disease process, it was a classic paper. It talked about the mortality, the surgical early mortality was almost as high as 30%. So think about that. 1 out of 3 people who got to the physician, who got to surgery, still succumbed of the disease. Now, over the course of 30 years, we've been able to reduce that in high volume centers to about 10%, but that's still very high. If you really think about 10%, 1 out of 10 will still succumb to the disease. So even better is getting to them before they have the dissection. And that's where Dr. Eagle was talking about, this concept of all the calcium score CTs that are being done now to look for coronary disease. Well, you're going to pick up a lot of these aneurysms that now we can follow, and then we can watch those patients. And I do believe if patients are being followed appropriately, their risk for developing dissection goes down. So I think it's important to understand, prevention and treatment and those two differing populations that we really need to attack, as Dr. Eagle mentioned to us earlier, hand-to-hand combat. We like that analogy. So,
And if I could just jump in, Tony, and Kim, thank you for this. I think this is fantastic. But just to kind of bring back to like a real life example, my OBGYN was the one who was telling me I was having an aortic dissection. So she was such a critical part of my story. She was the one who ordered the CT that ultimately found it because she had heard my family history and I advocated for myself. And so I'm extremely passionate about everyone, at all points of care, understanding aortic dissection. But beyond that, 2 years ago, the John Ritter Research Program found the gene that was causing aortic dissection in my family. So we have now since screened my sisters. One sister has it and one doesn't. And so her care is going to look so different. The one that has the mutation, it's going to look so different going forward. And she's going to be able to have that preventative care, Dr. Estrera, like you're talking about. And my son is going to be able to have that care so that it's not going to sneak up on us. And we're lucky because we know we know our mutation. Some families aren't so lucky. So if they're screened, to your point, Tony, if their doctor orders those correct imagings, right? Whether it's an echocardiogram or something like that. I really believe exactly what you guys are saying, that if all of us, including the patients, are active parts of these care, we can catch more of these people before it turns into dissection.
Thank you.
Thank you all.
Thanks.
Anything else you wanted to add before we move to the Q&A?
I want to just expand a little bit on what Tony said. Obviously, if we think about a person out there asking the question, could I have an aortic problem? Obviously, it starts with thinking about their family history and then thinking about things that we've already talked about that might make them at risk, whether it's a valve problem or tough hypertension or something else. And sometimes it's an image that's done and it accidentally identifies a slightly enlarged aorta, which they and their provider have to recognize could be a footprint to a problem and needs to be further evaluated and then watched. Obviously, if they're having an active symptom that could be a dissection, um, usually severe onset of pain, we want the providers to that patient to be armed with the clues that that type of pain might be caused by an aortic problem, how it presents, the family history, other markers that say, yeah, this person has a higher chance of aortic dissection. And then survivors, of course, they have the disease, but we have to help them live and thrive with the disease. Careful surveillance, excellent medical therapy, and an aortic team that's prepared to help them all along their journey. Um, Today, we're trying to raise awareness for everybody to understand the clues and try to fight and prevent the kind of catastrophe that John Ritter suffered a number of years ago.
Thank you so much, Kim. Did you want to add anything else, Dr. Estrera?
No. Thank you, though.
Thank you. Thank you both so much, and Meredith for sharing your story. We're going to move to the Q&A, and I think we have a couple of questions that have already come in. Tony, in your view, what is the biggest opportunity we have right now to raise awareness amongst the medical community and the public so fewer cases go undiagnosed?
I think I think about the education, both of our community, but also the general public. And that's why this forum is so important to get the awareness out. And I appreciate the work that the John Ritter Foundation has been doing for almost 25 years now, since John Ritter's death. But, it's still real though. Still a real problem because I unfortunately, as Kim said earlier, on the front lines, we're still seeing these devastating, you know, aortic catastrophes being referred to us, here in Houston. And someone asked me this earlier. We're probably seeing 70 to 100 of these cases each year. So it's not a tremendous, not as many as heart attacks, but these are such devastating situations, conditions when they do occur. And the fact that we're still seeing so many of these, we just need to continue pushing, the envelope and pushing the message to get people aware and to be their best known advocate in my mind. I know through, publications in our field, the aortic, problems, surgical and the surgery side and the cardiology side has gotten a lot more press in our meetings. So we'll continue to, publish and do our research in these areas. I do think there's a lot of great work being done. This whole advent of AI, this is very fascinating to me. And and Kim mentioned earlier about all the CAT scans being done. There's AI being utilized to sort of pick up on all the abnormal aortas now that are being captured by just these routine CAT scans. And there's some work being done with our group. One of the investigators at UT is looking at facial recognition, and that would be sort of neat. The patient comes into the ER, you use AI and facial recognition to determine if they're at risk for dissection or aneurysms. It's this kind of research being supported by John Ritter Foundation that really is exciting and that can maybe get us to that next level because it would be great. And I hate to say it as a surgeon, it'd be great that if I never operated again on a dissection because we could prevent it, with some other modality and identify it. I know Kim will still be in business. I'll just have to retire, but that's okay. So
That's right. Thank you, Tony. I have another question from Bert Cohen. Patients at risk understandably may be fearful of taking the step to have prophylactic surgery. Can you briefly describe what that entails for both dissection and aneurysm for you, Dr. Estrera?
Yeah, that's a good question. So this is a very tough discussion that we have to have with patients, because I tell them up front that I am going to hurt you before you feel better. Especially, they have been feeling well, they identify they have an aneurysm, it's causing, no big issues except for just being there. But the guidelines suggest that we should replace these aortas with prophylactic surgery, because now the risk goes way up. And I never force anyone to do surgery, prophylactic surgery, but we have this shared decision making and a long discussion about what this all entails. And this is why John Ritter Foundation is important, because there's that support group that's available to these patients so that they can go and talk with Meredith or some of the other patient Ritter advocates and get an idea of what this is all about. Because with that knowledge, it gives them a little more strength about what to expect. Because it is scary. It's absolutely scary. And I'll admit that these surgeries, we do very well, and Kim's group in Michigan have great results. I do admit you probably should go to a center that does high volume and has a good team, because it's not just one aspect. You have to have the whole team involved. But I do think, for the most part, you can have really good results. And what's really good? 1 to 2% major complication or mortality death is always going to be that number that we have to quote as surgeons. And then it goes up there. But think about the mortality of aortic dissection when that occurs. We're talking about 10 to 15% in the best of hands. So we're talking about survival, and you have to weigh the risk and the benefits of the surgery. But we always have this conversation, and I want the patients to really come to terms with what they're getting into before they really make that decision.
To expand on that, I think, Tony, based on the family history, the aortic size, its change in size, perhaps over time, if there's a known gene, we know there's this moment where the risk of not operating becomes as great or greater than the risk of operating. And if the family and patient can start to understand that by going through the surgery, we are actually lowering the risk of mortality, both this year and in subsequent years, because we've solved, in some circumstances, sort of a ticking time bomb, if you will. And it's so important that decision be informed so they can really understand that trade-off. And I think once they do, in general, they're going to say, well, of course, I want to live. And if I have to go through a bit of a rocky period here in order to gain that survival advantage, I'm all for it.
Thank you, Kim. I'll also add that not every operation has to be an open major cardiovascular operation. Technology has advanced to where some of these patients we can take care of with endovascular procedures, catheters based procedures with stent grafts, and never have to open the patient. So technology continues to advance, and that's why it's real important to talk to your caregiver, your interventionalist, when you're trying to make these decisions on what's the best treatment.
And I'm just going to add one really quick thing. The group that Dr. Estrera, that Tony was talking about, is called the Aorta Advocates. We've trained volunteers within our community to be advocates, to help people be their own advocates, and they're just a sympathetic ear. And so we do have people who have had aneurysms replaced or are awaiting surgery, because it can be a really tough time for people mentally. And that's actually where people reach out to us the most recently, is people awaiting surgery. And so thank you for bringing up that program, Tony. And then Tony, you used at one of the conferences that I attended with you, you used something that I use all the time, is that when you have an aortic dissection, it's like you got hit by a truck twice. Whereas if you have a preventative surgery, it's like your body's only been hit by a truck once, because it is a trauma, right? But the dissection itself is like being hit by a truck, and then you have to go into open chest surgery emergently. So I use that all the time. I don't know if you use that, but
Oh, yeah. I used it twice this morning.
oh, there you go. It stuck with me.
I mean,
So I like that analogy for patients is yes, it's not great to having open chest surgery, but if you wait and you have the dissection, you may not make it, but also, it's like being hit by the truck twice.
Yeah. Meredith, you mentioned, and that's a great segue, the aortic advocates. What's one piece of advice you would give to someone or a friend who was recently diagnosed with the aortic dissection?
First of all, is find it actually refers back to the Ritter rules that we just discussed, is find the right team, right? If you have the right team, and we do have resources on the John Ritter Foundation website. We refer a lot of people to the Marfan Foundation Clinic directory. Uh, but definitely find the right team because they can answer a lot of questions and really help with your mental health piece of it, being willing to answer questions. So that's the number one. But also number two is talk to your family. So if you've been diagnosed with an aneurysm or something, you're already light years ahead of a lot of other people, and you can help protect your family. So not only know your family history so that you can advocate for yourself, but make sure your family understands their risk now and their family history. I know you asked for one, but those are my top two.
Thank you. Very helpful. And I think we have one last question. If there are any more, please do send them into the chat, the Q&A. But one last question for Kim. How can physicians better integrate genetic testing and family screening into routine practice without overwhelming patients or systems?
Yeah, it's a great question, and the availability of genetic screening is highly variable across the country, and much less so in rural areas. I think there's two answers to this, and I'll be interested in what Tony and Meredith think. I think number one, the use of AI, as Tony mentioned, in our electronic medical records offers the potential for uh, us to get pop-ups that identify, this patient who you're seeing um, had an enlarged aorta on an echocardiogram and, in 2022, or had a calcium score study where the aorta was pinged, or has a family history of sudden death that was unexplained by autopsy. So that's a distinct possibility that I think we're already beginning to exercise. The other is, I think, virtual health visits uh, can be a real boost here, where you don't have to travel 3 hours to get a genetic consultation, but potentially you can do it through a Zoom or team call and get the answers that you need. We talk about genetics in this webinar as if it's kind of a routine test. It's not. Genetics is very complicated. And if we test you, Rachel, for known aortopathy genes, uh, the chance of finding it 3 times more likely will be that we might find a variant that could be a connected gene, but we're not sure yet. And so when we do genetic testing, we have levels of uncertainty that sometimes are hard for patients and families to deal with. And so we need an excellent genetic counselor to help us walk through that and then follow it over time, because their variant may become known to be a pathogenic variant, a causative gene later in life. So there's a lot of nuance, but I think the use of AI and the use of virtual visits offers us some hope to do a better job than we're doing right now.
Kim, I'm just going to go off of that because my genetic test was inconclusive for many, many years, even though I was the fifth dissection in 4 generations. And so you bring up a great point. A great genetic counselor is incredibly important. And there are services out there exactly to what you're saying. And we have information on the John Ritter Foundation website of these genetic counselors that can work across all 50 states virtually. And so I do think Dr. Eagle, exactly what you said is incredibly important, is the genetic counseling if you're going to go that genetic route. But that is screening that is less cost prohibitive that your family can do as well, if that conversation can be had. And again, when talking to patients about putting this into your care, we do encourage making sure to talk about the mental health aspect of it. Tony and I actually worked with a patient together who came to the foundation, and his anxiety around it was just so crazy, not crazy, but just so high that Tony was able to really work with him and figure out a plan that worked best, not only for his aorta, but also for his mental health. And I think that's incredibly important as well.
To just last comment regarding Kim, your comments on the genetics, I do think it will eventually get there where we can identify specific genetic mutations that will help guide what we do. I bring up the example of a young woman, a young girl from another state who we treated a few years ago. And Diana Milowitz, who's funded by the John Ritter Foundation, was able to identify the specific mutation on this young girl. Now, it was a tragic story because the mother came to Diana and our group because her two other sons had died and her husband had died in their 20s and 30s, and she was the only one left, and her aorta was completely normal in size, completely normal. And I had a hard time, sort of justifying the operation, but she had the exact mutation that they all had. So I always thought of the movie Saving Private Ryan, where they went back to get the one soldier because the three other brothers had died. And I sort of equated this as like that situation, and we fixed her and did a valve sparing root replacement, and she's done well. But it will get to that point, I think, where you have this really personalized medicine using genetics. Your thoughts, Kim?
Yeah, I totally agree with you. And I think that with, through the Montalcino collaborative that Dia and others have led, we are getting there. We're beginning to see uh, gene-specific effects on aortic behavior that allow us to be more precise in our estimation of when to operate. Our hope is that in the future, these also might lead to more tailored medical treatment and surveillance protocols. And one could imagine, if you're really an optimist, that through technology like CRISPR and other things, perhaps in the future we could actually alter genetic effects and prevent aortic aneurysms and dissection. I think we're moving rapidly toward precision health, and genetics and imaging and AI and electronic records. All of those are fair game to try to push the field forward.
Thank you. Thank you, everyone. I think that's all the questions we have for today. Appreciate your participation. Special thank you to Dr. Eagle, Dr. Estrera, and Meredith for participating in this. To the reporters who joined this call, please reach out to us if you have any additional questions. As Meredith mentioned, we have a number of other patients and many stories if you have a specific angle or would like to talk to a patient. Any additional questions, please just reach out. We really appreciate your support in getting this very important story out there. We really do believe aortic dissection deserves headlines, and we'll do anything we can to help you with your stories. So thank you all very much and enjoy the rest of your day.